we have come to the end of the session with the last speaker, and today we'll be hearing from Dr. Nagarjuna Burela, a consultant oncologist for Proton, and he'll be talking on proton therapy in cancer patients. You all know that we learned in physics, chemistry, electron, proton, neutron, what an atom is made up of. An atom is all situated in millions of molecules we have, and how this proton is channelized to a beam and how it is given for specific treatment in cancer. And we have with us to talk on this Nagarjuna Burela, who had his education at, he finished his Dipend in radiotherapy from BMC HRSC Jaipur, and he had his clinical training in proton therapy at the University of Tsukuba Hospital, Proton Radiation Research Center, Japan, and he's been a dynamic proton oncologist, and he has been having a lot of certifications in India and abroad, and he has produced a number of papers internationally as well as nationally, and his special areas of interest are skull-based tumors, head and neck cancer, breast oncology, and other solid margins. We have with us a young dynamic speaker here to talk on proton therapy.
Thank you, sir. Thank you so much for the nice introduction. And thanks to everyone for coming today with our invitation. So as when they asked us what topic to be present, so it was, I was given the topic as like how to, to importance of protons. I know the crowd of like first time, like I want to introduce about the radiation also and what and its outcomes, and also but after treatment of the cancer. Okay, everyone, there is all modalities after treating cancer. So once the patient is cured, how is his survivorship? How is his quality of life? That is very much important than once we have cured. So with this background, in the next my few talks, I will tell basics of radiation and tell what is the difference between the conventional radiation and the proton, and what benefits we are achieving with proton. So this is the GloboCan data as incidence and everything. Dr. Sujit also has explained that incidence of non-communicable diseases is increasing, and you can see that new epidemiological transition among the different categories of NCDs, where in the red box we can see that the cancer is the leading cause of mortality in the low middle income countries like India. And if you see based on the, here this is also from the GloboCan, if you see the Human Development Index, HDI, we come under that orange color, that in the middle. So in the next 2 decades, there is an increase of 64% of the cancer incidence. It's like automatically like increasing from 2.3, the number of cases increases to 64%. And we know that cancer treatment has been evolved even in the investigation point of view or in the treatment point of view. So the pathology and imaging, these both are the main pillars of the oncology. And along with that, the precision oncology and personalized medicine has come into existence. Here you can see the lot of things like whatever the advances by Dr. Sujit has explained, that immunotherapy, CAR T cell therapy, genomics, and by Dr. Srivatsan has said about the robotic surgery and sentinel node. From the radiation point of view, yes, high precision radiotherapy like image guidance, MRI guided radiotherapy, but not least this particle beam therapy. So what are the next generation advances in oncology that revolutionize and dominate in the next decades? If you see, these are the few categories: oncogenomics, AI, that is artificial intelligence, robotics, immunotherapy, precision medicine. Not but the last is the modern proton therapy. How? So before going to the about the rest of the things, this is the basic thing. This is the electromagnetic wave spectrum, and we are interested about the right side of the visible light. So that is the whatever the right side of the visible light, ultraviolet, X-rays, and gamma rays. These all are ionizing radiation. Ionizing means they break the DNA of the cell. So that is what we require to break the DNA of the cancer cell. So what exactly is the radiation? In simpler terms, by the high energy particles like X-rays, we routinely see whatever we take X-rays, that is very low dose X-rays, when we take the chest X-ray. And when these X-rays are bombarded with very high energy, and this high energy, when it goes into the cell, it damages the 2 strands of the DNA. So then the cancer cell is dead. That means when it tries to divide, the cancer cell is dead. Even simply damaging the two strands of the DNA is not dead. When it tries to divide, it loses its potential to further propagate. So what types of radiation we have? There are two types of radiation. Photons, this is the conventional radiation. X-rays and gamma rays. X-rays is nothing but electrons. So where we routinely see in and around of our the treatment units, cancer units, this is the conventional treatment that happens with the photon. In the rest of the slides, for the rest of the slides, when I use photons, means this is the X-ray based treatment. X-rays is the electrons, and other type of radiation is the particles, either protons, neutrons, heavy ions like pi mesons. These are the heavy particles, and we measure radiation in terms of gray. So how the cancer cells get damaged by the radiation is either two mechanisms: single strand break and double strand break. But we are most important thing is double strand break. When the two strands of the DNA get damaged, only the cancer cell dies. If single strand of the DNA is damaged, it tries to recover, and it tries to clean. Tries to recover the damaged part of the DNA. But two strands of the DNA has to get damaged. It is done by the direct X-ray photon. It directly goes and damages two strands of DNA, or it oxidizes the water particle in the cytoplasm and releases the radicals, and the oxygen radicals will damage the two strands of the DNA. So the 90% of the treatment, the cancer cell damage happens because of the indirect action of the indirect action damage. So nearly 40% of cancers require radiation, and in the low middle income countries there is increased utilization of radiation units. And if you see the evolution of radiation since the last 6 decades, if you see that whenever we have used this is the first clinic in 1960s, you can see that there are only two jaws in the snout. This is the linear accelerator machine. If the tumor is here, they just open the X and Y jaws and then they fire. So afterwards, when the fact there are so much of unnecessary radiation going to the surrounding tissues, so they have developed this cerebral blocking, multi-leaf collimator, dynamic, and high resolution IMRT. I will come in the next few slides. What is the basic difference? See, this is the in simpler terms, if I see this dose sculpting, means like this exactly the shape of the man is the actual. If you consider it as the tumor. In the 2D era, like in 1960s, when they opened the X and Y jaws, we treat this, but this unnecessary extra radiation is going to the tumor that is beyond the tumor. That is in 2D planning. Once the 3D planning has come, we are able to modulate the beams, that we are able to exactly fine tune the tumor according to the shape of the tumor, because tumor will not be in square or rectangle, it is so irregular. So we have to be so confined to the tumor. And you can see this is the standard of art of technology till now we are practicing is the intensity modulated radiotherapy technique, where each radiation beam is matched the tumor. There will be beams treating on each and every angle, and each angle has takes the shape of the tumor. So in simpler terms, yes, see if I say that this concave shape is the tumor, and here is the spinal cord. So when our main intention of a radiation oncologist or radiation therapist is we need 100% of the dose to this concave shaped tumor. So here the red is the 100% dose. When we treat with X and Y jaws, you can see that not only the tumor, even the spinal cord nearby and also the surrounding tissues is receiving very high dose. The next is in with like when we treated cobalt or with in 1960s or 1970s the radiation modality what we treat, and with the use of cerebral block. This is the tumor, this is the critical structure, either spinal cord or anything. With the 3D conformal radiation technology, by using the cerebral blocks, we are able to confine only to the tumor area. But still, you can see that the green is the low dose area that is spilling outside the tumor area. And next, there has come the multi-leaf collimator. That is when treating the linear accelerator itself takes the shape of the tumor by moving the collimator jaws from the snout, that is where the beam comes out of the radiation machine, that is called the snout, where we can confine exactly and spare the critical structure and decrease doses to the surrounding structure. Next comes the this VMAT, the volumetric modulated arc therapy. There is the IMRT, where we are able to confine completely only to the tumor and able to spare the critical structure. So, but still, this is the standard of art that we are following, but we are still stuck with the low dose radiation that we don't want. This is unnecessary radiation that patient is receiving, but we don't want that. How can we mitigate it? Yes, see, the main, over the decades, even the technology in the radiation has been improved. The main background, you can see that nowhere we are compromising the dose to the target. So 100% of the dose should go to the target. So where the development has occurred, the technology has advanced. How much the tissue, normal tissue, we are sparing. See, the initial is 2D, 3D, IMRT, and SBRT and particle therapy. We have so much conformal radiation to only to the tumor, not to the surrounding tissues. So the whole technology has improved how we can reduce the dose to the normal tissues so that the toxicities are less, so that the further quality of life of the patient or after radiation will be better. Yes, this also sells the same thing, like reduction in the normal tissue dose with improving the radiation technology. And the few terms that we routinely listen is the stereotactic radiosurgery, where we use single session to the brain by treated with gamma knife. Stereotactic radiotherapy, where we treat 3 sessions to the brain, either by gamma knife or cyber knife. Cyber knife and SBRT is the stereotactic body radiotherapy treated outside the cranium structures, either any outside the brain. And routine is full fractured 30 to 35 sessions, that IMRT, IGRT, and VMAT. So this is how we have improved by improving the conformity from 2D to 3D. Where various technologies like IMRT, VMAT, TOMO, CyberKnife, LINAC, MR-LINAC, and ion beam therapy like Proton, Neutron have improved the anatomical conformity. Conformity means exactly treating the only tumor. The more the conformal, the better the toxicities are less. So adoption of new RT technology in India, yes, we have all the technologies, and if you see the gamma knife, we have gamma knife, brachytherapy, stereotactic, TOMO, cyberknife. Last but the least, this proton therapy also. We are at the forefront of having all the technologies in our India. So first hospital-based proton therapy facility where they have practiced is in Loma Linda, that is in 1990. 1990 is the first therapeutic implementation of proton therapy to the patient. So though the research of proton therapy has been going on since 1970s and 1980s, but the first treatment for the patient has been started in 1990s. So this cartoon, for the audience, you can easily understand. So there is a mosquito like mass of electron. That what I told, that the conventional photons, what we treat with X-rays. If you think of that, the mass of electrons, the conventional electrons, where the electrons are bombarded with high energy and produced photons, that are X-rays. That is mosquito size. And if you see the mass of proton, this is like nearly 2000 times mass of electron. So, and if you see the carbon ion, this is a very high energy particle. This is like 12 times mass of the proton. So if you can see that there is a serial increase in the mass of the particle that we are using. So with this, you can say that the proton has two advantages. One is physical advantage, the other is the biological advantage. So what is the physical advantage? Physical advantage is the Bragg peak. So simply, what is the Bragg peak? I can show this picture. Yeah. So everyone knows that in our Diwali, maybe we actually fireworks we use our skyrocket firework. So what does it do? When it goes up, it uses minimum of its very less of its fuel, and at a certain point it blasts and all of its fuel is utilized. Same concept can be given to the proton. When the particle goes inside the body, very less of its energy is utilized till it reaches the tumor, and where it is when it reaches the tumor, all of its energy is deposited. That is like nearly 99.99% of its energy is deposited. And this peak is called the Bragg peak. So what we are gaining with this Bragg peak? So when the Bragg peak, the conventional radiation from the entry of the body, there is very high dose, and then the dose decreases. So, but compared when comparison with protons, very less energy deposited at the skin, and only at the tumor area there is a very high energy deposition. So now we are benefiting with protons, that this extra radiation, this grayish area, where we are delivering with normal radiation, is avoided. So when there is no dose, no toxicity, and there is potential impact, there is less toxicity, sharp, precise dose delivery, even reduced the incidence of second cancers, because this dose itself, radiation itself causes the second cancers in after 10-20 years. And this is the cartoon which tells us that, you can see that in conventional radiation, when the beam passes into the body, it traverses from the skin and through the tumor and comes out of the body, and it travels. Whereas in proton, it exactly stops at the site of the tumor. So what we are, because what we can say that this is entrance dose, this is exit dose. This is entrance dose, here no exit dose. So in normal conventional radiation, there is an exit dose. We are seeing the more dose or unnecessary dose beyond the tumor. Beyond the tumor means there are normal tissues beyond the tumor. Either it may be spinal cord, either it may be mucosa, either it may be lung, which what side effects will cause, and the next slides I will let you know. Whereas in proton therapy, there is no exit dose. So this helps, this physical advantage helps us in treating with proton therapy more precisely. And the biological advantage, I will wait, I'll skip this slide, sorry. So, and the biological advantage is the main. I told the mass of the proton is nearly 2000 times of the mass of electron. So, simply either you are hitting with a small rock or big rock. The more the big, the more the damage occurring to the cancer cell. So, simply with the more heavier the particle, the more double strand DNA happens than single strand DNA. So, what we want, double strand DNA. So, there are clustered DNA damage happens with the heavier energy particle. So proton has more double strand DNA break than electrons. Carbon ions have more double strand breakage than protons. So simply that is this. When we compare with the normal radiation, because of this double strand DNA damage more, the relative biological efficiency is 10% more than the normal conventional radiation. That is what we say RB 1.1. This is a biological advantage. So physical advantage is Bragg peak. Biological advantage is of this RB 1.1. Both these physical and biological advantages help make the treatment delivery more precise. So here we have the modern proton beam therapy, because what is modern means, initially proton beam therapy it is passive scattering. Passive scattering means a bunch of proton particles come over the snout or open from the snout and then hit the body. Whereas modern proton beam therapy is pencil beam scanning, where the proton beam comes out of the cyclotron and passes from the snout. Here two magnets. These magnets steer the. Sorry. So these magnets steer. Actually, the beam is moved along the tumor. So line by line and also from distal to proximal, spot by spot, line by line, layer by layer. So the beam, actually you can see here. So wherever the beam, these two magnets steer the proton beam, and it deposits one spot here, and next goes to the next spot and treats from distal to proximal. This is that spot by spot, line by line, and once it treats one layer and comes proximally another layer. So in this way, that spot by spot, line by line, and layer by layer, we are using this pencil beam scanning. So it is so precise, so conformal in treating the tumors. So how do we really see dosimetrically, if we see what difference we are getting? So here 3 plans. This is a conventional radiation. We are interested in this is the red is the tumor, and whatever the blue and green, what is showing is the unnecessary radiation that we don't want. And if you see the proton, all the things are avoided so that we can reduce dose to femur, bladder, and bowel. So exactly this is the dose difference compared with the proton and these conventional modalities. This is the radiation that we don't want, and so that we can reduce the toxicities. This is the physical advantage translates into the normal tissue sparing. That is because of the Bragg peak. And in pediatric patients, when we are treating craniospinal irradiation, which is the 100% the indication for proton therapy. How? Because when we treat craniospinal irradiation, we are treating the whole brain and whole spinal cord till thecal sac. So when we treat this with the conventional radiation, we have to save the mucosa, here esophagus, anterior to the lungs, bowel, genital organs. These all structures will not be able to avoid with conventional radiation, but with proton therapy, we are able to decrease the doses to these structures. Why? Because these pediatric patients do well, they are curative, they are cured, and they live for 10 to 15 years. So when we don't avoid these things, these kids may have the side effects of this radiation, like stunted growth or some dysphagia like swallowing issues, like intellectual cognitive issues, all these things. So these can be avoided. So this is the biological effect that what I said. I think this slide came a little later. So double strand DNA. So where actually the potential impact of this proton therapy is, there are various sites. First, see the pediatric cancers. Yes, the indication for pediatric cancers. Why I can say that this is a craniopharyngioma. Craniopharyngioma is the non-cancerous brain tumor where it arises near to the pituitary gland. So, so when we want to treat after surgery, radiation is indicated for this craniopharyngioma. There are vital structures in and around. You can see there is optic nerve, hippocampus, temporal lobe, brainstem. These are the structures that really to avoid while treating, because these have neurocognitive effect. The more the dose to the normal brain, the neurocognition effect in future, and also the optic nerve that helps in vision is a compromise. And so by using proton therapy, lesser neurocognitive decline, and also lesser endocrine dysfunction, spares vision, potentially lesser strokes and second cancers, and lesser disabilities, dysmorphisms, means like standard growth. These can be avoided, and spares fertility and reproductive failure. Because in patients who are receiving CSI, the gonads are nearby to these sacral and coccyx, so that can be avoided. That spares the reproductive issues. And this is how the beam, when beam comes through one side, we can avoid the doses to the opposite side, the brain and normal tissues. And this is also the brain. This is the glioma, where we can, when we treat this whole part of the brain is saved. And next comes the thoracic cancers. Yes, thoracic cancers. When we treat radiation, we are avoiding completely the normal tissue here, and also the hard doses, thus reducing the cardiovascular issues, and also helps in by reducing the nodal stations like immune sparing. And in breast cancers, yes, we can reduce the doses to the heart, opposite breast, contralateral breast. Why? Because when the dose spills to the contralateral breast, there is incidence of having radiation-induced breast cancers in the opposite breast, and also the lung toxicity and cardiac toxicity is reduced. And in prostate cancers, yes, we can reduce doses to the bowel effects, bladder, and urinary and sexual dysfunction. And in brain, in head and neck, this is the esthesion neuroblastoma. There we can avoid the eyes. Why in terms of head and neck, I can say that, see, when we do the CT scan of a head and neck patient, there are many vital structures. There are the lips, buccal mucosa, parotid, constrictors, because lips, buccal mucosa, these help in, because the main side effect with radiation is, see, if there is a tumor in the near to the tongue or near to the buccal mucosa, when we give radiation here, the dose may spill onto the buccal mucosa. That causes mucositis, that is inflammation of the mucosa. That is very hampering for the patient to swallow and eat, and also doses to the constrictors. If the more doses to the constrictors, the patient will end up in dysphagia. The dysphagia itself again compromises the nutrition, and the parotid glands. Parotid, when the parotids are fired, it causes the dryness of the mouth. So these all things, when we treat a head and neck cancer patient, it is not easy because there is so much of morbid will be there while treating head and neck patient, because we have to treat this tumor and we have to reduce the other sides of the side effects of radiation, like mucositis, xerostomia, dry mouth, and dysphagia, because this all together make the nutritional compromise for a patient, which ultimately makes patient nutritionally compromised and needs admission. That itself makes the treatment breaks, and when the treatment breaks are happening, the treatment duration will increase, which ultimately affects on its local control. So here, when we are taking, this is the head and neck, when we are taking the nasal cavity, we are able to reduce the doses to the eyes and also the nasal mucosa. When we are treating the buccal mucosa, we can completely reduce the doses to the opposite buccal mucosa and oral mucosa. Similarly, in GI, liver, yes, focused, and we can save the normal liver. So when we treating the liver tumors, this is not like anyone can treat with radiation, but how much liver you spared is very much important. Why I am saying is this, because there is radiation-induced liver disease that hampers the liver functions further. So even if you are cured of liver cancer, but if he is on RILD, if his liver functions are deranged, his quality of life is very bad, and he is having so much of lot of issues. So here, by only concentrating on the tumor, we are sparing the normal liver, so that it doesn't hamper its the liver function tests. So mainly in patients with cirrhotics, it is very much beneficial, And whenever the tumors, even HCC, even large tumors also, it is very beneficial because we can save the normal liver. So mainly benefits of proton, yes, better normal tissue sparing leading to lesser incidence and severity of both acute and radiation related side effects, and increased biological dose, and hence potentially better tumor side effects are there. So this is one example that when we treated, it's like patient treated like 6-7 years ago, received craniospinal irradiation, now not going to regular school, unable to focus and learn, unable to walk, has been continuous neuro rehabilitation where he had it with photon techniques, growth stunted, has endocrinopathies on hormonal supplements, there are skin changes, hair changes, frequent infections, obese, major psychological issues like comparison with the younger sibling. Even in the same family, the kid itself, himself may compare with his siblings, so that may hamper his psychological issues. So these are the patients, these are the kids who survive and has very poor quality of life. Even there is increasing burden. This is the article stating that there is increasing burden of long-term cancer survivors. See, nearly childhood cancer survivors, nearly 63% have at least one chronic medical disease. Either they might be having stunted growth or hormonal supplements or something. And 27% are having severe life-threatening. See, most of them are able to start their education and employment, but still, when we compare with their peers, they have this all late reactions. So there should be a balance between long-term surveillance versus high-quality survivorship when we are treating such type of patients. So strategies to mitigate this, whenever necessary, we have to avoid, but high conformal radiation therapy techniques with CRISPR margins really helps in avoiding these late side effects. So even the ASTRO, this is the American Society of Radiation Oncology, they also suggested that what are the indications for proton beam therapy. These are the group 1 indications where the tumors that are close to the skull base. I mean that where the lesions are very close to the skull base, that is opposing the brain or optic nerve, optic chiasm, or the pituitary gland, the proton therapy has to be considered. It is considered as a standard alternative. And it also has the group 2 indications, which is an emerging evidence because there are no randomized control trials still yet to come. So this, you can see that in US, the number of patients treated with proton therapy, you can see less than 15 years, the curve from 2004 to now. So mainly the pediatric patients are getting used with proton therapy. And compared to the adults down here, this is the adults. And here the green boxes, these are the indications and the green boxes. These are the patients who have received proton therapy in adults. Compared to pediatrics, there are many wider indications, and which is followed by not only UK, US, and in the West. So there is main in its usage is definitely there 100% with the pediatrics, and it's wherever the tumor is close to the skull base and where we want the quality of life to be better and decrease side effects. So with this background, I just want to show the proton treatment facility in whatever the facility we have. See, this is the so this is a machine that is not easy that to bring and commission it. So the actual thought has started in 2012. There are quite a lot of challenges with the ARB approvals because this is the only first time we are bringing this proton technology into our country. So ARB, that is Atomic Energy of Regulatory Board, which has given regulatory permissions to the photon machines, but with the proton they also new. So there's a lot of challenging for them and us also. So finally we are able to commission and start our first patient in January 2019. This is the layout of the proton therapy proton therapy facility. So what happens is, here is the proton source. So how the proton source generated is, we have pure hydrogen source, that is the small like a gas cylinder. So from the hydrogen source we extract the proton. So after extracting the proton, this proton particle is accelerated in the cyclotron. So it is accelerated because when we extract the proton particle from the hydrogen source, it is having very low energy. So when we need to get the high energy, it is accelerated in the cyclotron. How do we do that? This proton particle, when it moves circularly in the cyclotron, it increases its energy from nearly 1 MeV to 150 to 250 MeV. Based on the requirement of the patient's depth at the treatment area. So once the required energy is gained, it is transported to the beam path. This is the beam path where when it passes, it comes out of the cyclotron and goes until these are the beam path, and these are the 3 gantries. We have one fixed gantry, two mobile gantries, that is 360 rotating gantries. During the path, you can see whatever the red ones are there, these are the magnets. So these magnets make the proton beam to keep in the straight line, not to deviate further. So such high energy magnets are there to keep the proton beam line in the same path, so that it not deviated till it reaches the patient. So this is a cyclotron beam path, and whenever required, the beam is transferred to the concerned gantry. So you can see that this is the beam path. This pipeline, you can see this is the proton beam line, and this is the gantry. This picture I have kept because to show that how big compared to the on comparison, because when this is like 3-story building machine, that gantry machine, and finally the couch. This is the background I have shown right now, and this is the final where the patient lies on the couch, and this is the snout. And we have the 6D couch that rotates in all like 6 degrees freedom and requirement. This is the mobile gantry, 360 degrees mobile. It's like it rotates around the patient. So we have 3 treatment rooms. We have ambience also for the kids to be. There is coloring and then lighting, everything to make the kids comfortable while treatment. And nearly we have treated patients across 6 continents and 32 countries. And most of our patients are coming more than 500 kilometers. And we have treated nearly 1,500 patients till date. And minimum age we treat is 10 months old, and the maximum age we treat is 89 years old. So this is what we have. Key benefits is in the almost late effects are dose dependent. So the less the dose, the less the late effects. So mostly in patients with craniospinal irradiation, we have to reduce the doses to all the vital organs. It's proton therapy is 100% indicated in these patients, the pediatric, where we require craniospinal irradiation. So the summary of benefits: reduction in neurocognitive decline with the proton, better neuroendocrine preservation, and lesser organ dysfunction. That is what, when we decrease the low doses to all these structures, bone marrow, because most of our patients will be receiving concurrent chemotherapy. So for the concurrent chemotherapy means like when you readiation plus chemotherapy during the treatment time, we call it as concurrent chemotherapy. So the main side effect of concurrent chemotherapy is the counts coming down. So when we save the bone marrow and all these things, the counts will not come. Like we are achieving that counts not to come down, so that he will be suitable for the next chemo, for the next cycle of chemo. And lesser organal heart, lungs, salivary glands, bowel, kidneys, and preserving the fertility and the lesser probability of incidence of second cancers. And other link is improved quality of life also. So this is the we have dedicated OT and also the digital PET scan and MRI, and this is all of our patients who we see in our OPD will be kept in our multidisciplinary tumor boards, which will be going into the main discussions by all the radiation oncologists, medical oncologists, surgical oncologists, and then that's what we say, this cancer management teams we have specifically for all sites. So for all proton patients, once selected, we go into the proton peer review process. That is, once selected, we discuss among our radiation oncologists and physicists and therapists. We all discuss for the further plan of treatment. And the further, till now I have told the basics of radiation, proton therapy, and its usage, where it can be benefited. Simply the next few slides are since what we treated and what histologies it is benefited in pediatric, medullo, ependymoma, germ cell, ATRT, and pediatric. All these sets, and in adults also low to high grade gliomas and meningiomas. We have published our studies also, nearly 75 cases we have published that has been in reputed journals. This is the craniopharyngioma that I have published with my other like Dr. Rakesh Jalali, where we have treated nearly 20 patients, and we have seen that with a median follow-up of 24 months, there is local control of 100%. All the patients who are treated are surviving very better and doing well in their studies also. So these are the patient, the response. Initially the patient came like this, and this is a post proton 1 year follow-up where the regression of the craniopharyngioma we are seeing. This is the patient 2, cystic component, and there is no component now. After 1 year, and patient 3 with this is like normal patient and re-radiation, recurrent and re-radiation patients. All are doing well till now. And this is one of our like 17-year female patient with intracranial germ cell tumor, where we treated whole ventricular artery. Ventricle means we treat only the lateral ventricles, third and fourth ventricle. Nearly after treatment, she appeared for her exams, this +2 examinations, and she scored 3rd rank in her entire district. So when we see this is so gratifying that how our patients are doing. And similarly, the next site is like prostate cancers, where we can reduce doses to the you can reduce doses to the bowel. You can see that, which reduces the chances of having diarrhea. And also bone marrow, I told that the bone marrow doses are. This is the IMRT plan, this is the Proton plan. So we can see that all the colorful, whatever the colors you are seeing is the lesser doses. And here the lesser doses are also less, where we are completely sparing all these tissues. We have seen that in the prostate cancers, they reduce GI and GU toxicities. Yes, though the literature says grade 2 GI and GU are acceptable. See, for an elderly patient of 70 to 80 years, what is the grade 2 GI toxicity tells is the patient passing of at least 2 to 3 loose stools. And also our grade 2 GU is like passing urination, like frequent micturition, like at least for 3 to 4 times at night. So we can just understand that as such an elderly patient per day when he passes with the normal radiation with grade 2 toxicities, how it is impacting his quality of life every day going at night, waking up for 2 to 3 times and going to washroom, and then it really hampers his life. So that's how though the conventional radiation, it has been reported that grade 2 and grade 2 GI and GU toxicities are so and so %, which is acceptable. But I will not agree that when an elderly patient comes with grade 2 GU and GI toxicities, it is really concerning for a patient, though it is normal to you and though the literature says normal. So a proton really helps in curtailing these side effects. So even NCCN also tells that it has to be considered in prostate cancer. And even we have treated musculoskeletal tumors from chordoma, chondrosarcoma, soft tissue sarcoma. Nearly 150 patients we have treated. Here, one of our patients, you can see that large mass in the sacral chordoma near in the sacral coccyx. Post proton 1 year, it's like majority, like 80% as shrinkage happened, and we can see that patient is able to walk with a limb. Occasional analgesic has to be used. Constipated and bladder is functional. We cannot do surgery in these patients because when the sacral nerve S1 S2 component is involved, even if you do surgery, he may land up in foot drop and having bladder disturbances, incontinence. So that when we discuss with the patient what the modality here, what the it's like everything we keep in his in front of him and he chooses. So we went with the proton therapy. Now at least he is constipated, but bladder is functional and able to walk with a limb, and it is in control. Similarly, in head and neck cancers, yes, oral cavity, oropharyngeal, skull base, salivary gland, re-irradiations. I already said that mucosal sparing. It's like the more the mucosa you spare, the more the patient tolerates during treatment. So the less the mucosa it is, less the dry mouth, less the dysphagia. So he will have the nutritional proper so that it will not compromise his further treatment. So this is one of our patient like where it is very much close to the optic orbit, that is like it is indenting, it is pushing the optic nerve. After radiation, 3 months we can see the complete response, the very well respond. So this is the mucosal sparing technique. And in thoracic cancers, for example, here 63 gentleman T3N3 with mass in the left mid zone. This is the PET also showing. We compared as can we give with the normal radiation? Yes, we have planned. We can see that these are the threshold doses that we accept with conventional radiation. Though we give conventional radiation, there is a Quantec guideline says that okay, this structure, normal structure has to receive this dose when you are giving this dose. So if you don't cross the tolerance dose, yes, there will not be side effects or less side effects. If we are crossing above the tolerance, yes, the patient will have grade 3 toxicities. Yes, it is said that. So according to Quantec, here see, when you are treating lung, the surrounding lung parenchyma should receive this much. Like P20, we have our individual constraints that volume receiving 20 gray should be 30%, P5 55%, mean or dose less than 10 gray. Where what we achieved with the conventional, that IMRT plan is this, which is going about beyond our tolerance dose. So what we have done proton plan. So where we have used single like 2 beams, and we can see all these unnecessary doses, that is dose filling from 30 to 60 to 50 has been cutted. So here we are able to achieve dosimetry achieved. So though the dose parameter what we kept in IMRT is 29.8, it reaches 7.2. Along this 19.7 tolerance. Means like simply I'm telling that so that the doses can be reduced when there are prohibitive plans. Means like each and every patient cannot be selected for proton therapy, but we can select by comparison where there are prohibitive plans, like where we can't achieve best constraints with the normal radiation. Yes, they are eligible for proton. This is the patient after like 2 years, the complete response. And similarly in GI cancers, as I said that how much normal liver you are seeing, that is important. See, this is the patient after 3 months, there is a near complete response. And similarly, it has its uses in esophageal cancer, where we can protect the lungs, heart, and also the spinal cord. In pancreatic cancer also. And in the breast cancer, we can spare the hard doses, because it is said that the even 1 grade dose has 7.4% increase in the cardiovascular diseases in future. Means having the heart attack or congestive heart failure. Why? Because when we treat breast, this is the left side of the heart. This part, like apex of the heart and the left antidescending artery, is exactly sitting there. So with the conventional radiation, it is very hard to reduce the doses to the LAD. So because of the it's a physical property. No, but with proton therapy, we can see that it is advised that you have to achieve 1 grade. You can see the different techniques what it has. Heart mean dose 6.8 are done, but our experience is we have achieved 0.9 grade, and we have published. This is me and Dr. Sapna Nange has published one of 20 patients with proton, where we achieved our mean heart dose around 0.78. In the left-sided patients, like 0.87. So it's like these are really to be selected and to be educated actually. So nearly we have 1,500 patients we have treated, and multiple sites are done. Data being collected prospectively. We have low rates of acute toxicities. Larger percentage of our patients are recurrent and re-radiation. Regarding the cost, yes, as the footprint comes down, the cost comes down. And this is the last that actually when and where proton therapy is useful. The final, when the target volume is close proximity to the vital structures, and when there is cleaning, this is a increased clinically meaningful normal tissue toxicities. When there are prohibitive plans, we can use this. And re-radiation means like the patient who has received prior radiation, and when he comes second time, the tolerance doses for the normal structures are again very less. So when we want to achieve those constraints with the normal conventional radiation, it will be tougher. So that those patients proton will be benefited. So this is the article done in the West to know the cost effectiveness of proton. By simply, I can tell one example, like I said, the craniopharyngioma. When the patients receive have radiation for craniopharyngioma, in the West we know that most of the patients are like insurance, they bear the cost of the patient's treatment. So once the treatment is over and post radiation, the patient may have, as I said, that neuroendocrine deficits. So he may have been dependent, like he needs hormone supplements, and he needs because of lesser neurocognitive decline, he may need some extra support from maybe some other schools he may need, or maybe when there is stunted growth. Yes, it is all they have seen the total cost of this, like radiation cost and the cost that they are bearing for the rest of the next 10 years. So this is the cost effectiveness. Even though we see that initial treatment of proton therapy is cost, but if you see the insurance, the government bearing on the patient is more. So this is a cost effective analysis that has been done, and proton therapy offers cost effective for pediatric brain tumors and well selected breast cancers, loco-regionally advanced non-squamous cell carcinoma, and high risk head and neck cancers. So in what aspects it is cost effective? IQ preservation, reduced growth hormone deficiency. Like the people who have received proton therapy has less dependent on hormonal supplements like growth hormones, and reduced adverse events like neurocognitive and visual disturbances like that. So this is like we have comprehensive medical oncology services like which is led by Dr. Sujit Kumar. Here round the clock we have critical care support. Nearly we have completed 500 robotic surgeries, and we are in strategic collaboration with Miami also for the academic exchange programs. And not only this, we are doing many of our research projects are in pipeline. And not only we also do yearly annual proton practicum. This is like physical participants will come and we educate, and we do this practicum yearly once. This is a recent one, fourth annual practicum happened in July 2024. And I really thank our leadership, and we are the first JC accredited Apollo Proton Cancer Center, first JC accredited cancer center. And at last, I thank my seniors and also and the families of the patients who have helped me in doing this. Thank you so much. Any questions?